Hello, and welcome to the MedX instructional video on photobiomodulation. I'm Jerry Ross. I've been using photobiomodulation in my practice for the past 25 years. I've been practicing general dentistry for 47 years, and I have found it has been a fantastic tool to use in my practice. In this instructional video, we're going to go over how it works, some of the safety features, and we're going to show you how to use it in your own practice. So at the end of this video, you'll be able to use it successfully on your own patients right away. This is the Oralase. It has a safety key that has to be plugged in before it'll work. At some point, your laser won't work, and it's because the safety key isn't plugged in. It comes with lights that'll tell you exactly what the dosage is. A green light is 2 joules, a blue light is 4 joules, then both lights will be illuminated, and that's 8 joules. In your manual, you will have a guide that will tell you exactly what dosage to be used for different procedures. All you have to do is push the button. It'll deliver that amount of energy and will shut off automatically. It also comes with 2 different tips. There's an extraoral tip, a short one like this. This is what I use outside the mouth. It also comes with an intraoral tip. This is what I use inside the mouth. This is the MedX Home. This is the dual wavelength infrared LED device that I use in the muscles outside of the mouth. When I'm using the device, I like to wrap it in saran wrap. Our gloves may have blood on them, may have oral fluids on them, so the saran wrap provides protection. The tips themselves can be autoclaved. You can autoclave as many times as you want without degrading the tips themselves. At the end, I simply remove the saran wrap. I take the tip off. This will go in the autoclave. I take a wipe and just wipe down the unit itself. That way it's safe, clean, and ready to go for our next procedure. Like we did with the Oralase, the head is again wrapped in saran wrap. Now we're going to briefly discuss how photobiomodulation works, the scientific basis for what you'll be doing. The light is absorbed in the mitochondria of the cell, and various mechanisms happen within the mitochondria. The end result, if you look at the arrows, all the arrows lead to one thing. It increases ATP. What's ATP? It's adenosine triphosphate. It is a cellular energy that makes the cell work. Once that happens, it stimulates some cell signaling and gene transcription, and then we have numerous clinical actions happening. We've got wound healing, tissue repair, prevention of tissue death, relief of inflammation, pain, edema, acute injuries, chronic pain, neurogenic pain, neurological problems, and treating acupuncture points. Okay, that was a real mouthful. When patients ask me how does this work, I don't go over that diagram with them. I have a simple analogy for them. Think of it like a car. The mitochondria, that's the engine of the car. ATP, that's the gasoline that makes it work. The nucleus, that's the engine of the car. When everything's working together, the car runs and hums smoothly. That was a very complicated mechanism you just saw. And where do I get that information? It comes from an article called The Biphasic Dose Response and Low-Level Light Therapy by Wang, Chen, Carolyn Hamblin. This is basically the Bible that I find of how things work. The second really important thing in that article is something called the biphasic dose response, or the Arndt-Schultz curve. It takes a certain amount of light before the action occurs in the mitochondria. Once the light is absorbed in the mitochondria, you can have stimulation or you can have inhibition. A low dose, usually 2 to 4 joules per centimeter squared, is what we use for stimulation. As the dose gets higher, then you start to get inhibition. A clinical example of this might be dental implants. When the implant is placed, it might be a painful procedure. So I actually apply the tip right into the socket to stop the pain, and I use a high dose for that. But we want the implants to integrate with the best quality bone. So I bring the patients back twice a week for the next 2 weeks, and I use a low dose. I use 4 joules on each side of the implant to stimulate the bone formation. One of the mechanisms that happens when we're using photobiomodulation is increased circulation. This is a slide that illustrates again what I'm talking about. On the top, you will see a venule, a small arteriole, and a lymphatic vessel. Once the light has been applied, again, it's a low dose for stimulation. We've increased the diameter of all the vessels. So you can imagine we've got increased blood supply going to the area. The blue is the lymphatic system. That's the body's immune system. It's bringing in the cells that are necessary for healing and also taking away the toxic products. So whenever we're using this, we want stimulation. Now we're going to talk about laser safety. The ANSI standards, these are universal for all laser devices used throughout the world and are the same for every country. One of the prime requirements of every laser device, it has to have emergency shut-off. With the Oralase, it's this button at the end. As soon as that's removed, the laser will automatically shut off. The Oralase is a Class 3B device, meaning it's under 500 milliwatts of power. Everyone that's in the room where you're using the laser must be wearing safety glasses. The operator, if there's an assistant there, the patient, and if there's anybody else in the room watching, they also should have safety glasses on. Because the light shone directly in the eye could cause damage to the eye. So what you need are safety glasses. Now the safety glasses are of a specific wavelength. So you must make sure when you get them that it's for the wavelength that you're using. The second thing is the glasses have a marking of something called OD, which is optical density. This is the amount of light protection that the eye will get. The minimum standards for every laser wavelength is an OD of 4. So check your glasses to make sure that it's printed on them is the OD as well as the wavelength that you'll be using. One of the other safety requirements from ANSI is that in every operatory that will be using the photobiomodulation, the Oralase, you must post a sign outside saying danger. One will be provided with your device. I suggest just photocopying the sign and put it outside of all of your operatories. Okay, I've just given you a brief overview of safety. If you want to learn more, I know of 2 areas where you can actually expand your knowledge in laser safety. One is the Laser Institute of America provides an online course. It's a 2-day course that'll give you all the information you need to qualify as a laser safety officer. Second place you can find some information is the Academy of Laser Dentistry, ALD.org. They provide a safety video as a membership benefit to all members that explains safety for all lasers. If you're not a member, this video can be purchased. Now we're going to go into the operatory and we're going to show you how you can use the Oralase in your practice. When you get the Oralase, you're going to get a detailed guide for each of the procedures that we're going to show today. In addition, there's going to be a short 1-page guide. It's going to be laminated. You just hold in front of you as a quick reference guide to know where to apply it and what dosage to apply for all the different procedures. So let's go. The first thing we're going to cover is dental extractions. If I had to tell you where to start, this would probably be the procedure that is one of the easiest for you to do. It's also one that's going to be the most dramatic in its effects for your patients. So this is somewhere I'd suggest we start. So we want high dose. Remember the Arndt-Schultz diagram, we want inhibition. So we're going to use 8 joules, which is the 2-colored light, for routine extraction. If it's a more difficult extraction, I'll do 16 joules. And in a case of a multi-rooted tooth where it's a difficult extraction, I might do 8 joules down each of the roots. So when I want to apply it in the mouth, I aim the tip at the socket. You see it can be twisted. I apply it into the socket itself. I turn it on for the appropriate dose, in this case 8 joules, and turn it on. At the appropriate time, it'll automatically turn itself off. So if this was a surgical extraction, and we have a very uncooperative patient, he won't let me sit and do a flap on him. I don't understand why. But if it was a case where he had to do a flap, after we've sutured the flap up, we want to use stimulation because we want to heal the soft tissue. So what we do is we use 2 joules for this case. 4 joules is normally used for stimulation, but because it's over an area, we've got 2 joules the site, and where it's overlapping, we've got 4 joules. So we'd apply it here, turn it on, then move it to here after 2 joules, then we move it to here. We've covered that large area. After the tooth's been extracted and the Oralase has been applied, what are the real benefits of applying it? One of the biggest things I've found in my practice, I've cut down on the use of post-op analgesics by probably about 90%. It's very dramatic, and you'll just be amazed at the results when your patients give you feedback after you've done it. It also makes it heal faster, there's less swelling, and it is just an all-round win-win for the practice. Now we're going to cover the dry socket. This is probably the classic example where you'll be able to understand the biphasic dose response. When we applied it after the extractions, there's less chance of a dry socket. But unfortunately, some of our patients ignore all our post-op instructions. They go home and smoke. It most often happens to lower molars. They come back in excruciating pain. When they come in, I take the Oralase, I set it to 8 joules, and apply to the socket without having contact. Because they're not frozen, you can't apply it directly into the socket. I don't curette the socket at all. So I apply 8 joules, and I want the patient to tell me they've noticed a change in your pain. I keep repeating up until the pain starts to change. Not till it's gone, just till the pain starts to change. At that point, I apply the dry socket dressing into the socket, send the patient home, and I've never had to give the patient a prescription for post-op analgesics when they leave that day. The next day, they come back. In this case, I want to get some healing into the socket. Epithelium is going to cover the bone. That's what's going to provide the healing. So I use 4 joules for stimulation. After I've applied the 4 joules, I apply a dry socket paste into it, and the patient's dismissed. Following day, they come back, take the dry socket paste out, apply the 4 joules again, and send them away again with the paste in the socket. At that point, they're pretty well comfortable, and usually that's all the treatments they need. We'll now cover dental infections. If you have a surgical laser, it's antibacterial. Low-level lasers are not antibacterial, so by applying it to the site of the infection, we're really not going to be doing anything with the low-level laser. What we want to do is use the body's immune system to work on the infection. We're applying to the submandibular lymph nodes on the side that's affected. They are just below the first molar, underneath the jaw. It's actually very easy to find because when patients come in, it's going to be swollen like a pea, and it's going to be very sensitive to touch. So laser is applied to the submandibular lymph nodes. It's turned on, and it's going to apply 4 joules because, remembering the diagram we showed you earlier, how it increased the diameter. So we want to do a stimulation to those lymph nodes. Now we'll cover soft tissue lesions. Some of the most common lesions you're going to see in your practice: cold sores, aphthous ulcers, denture sores, mucositis, and some of your chemotherapy and cancer patients. When we're applying it, we apply it to 2 different areas. We're going to the lymph nodes first, submandibular lymph nodes. In contact, we're applying 4 joules for stimulation. Then we go to the lesion itself and do stimulation there. In this case, we're close to the lesion, but not in direct contact with the lesion. If it's a small lesion, we do it 1 time for 4 joules. If it's a larger lesion that covers a large area, we're doing that overlapping 2 joules again. Cold sores, aphthous ulcers, if you can catch it at the stage where they're just starting to get the tingling, that's the best time to apply it. If the lesion's there itself, you get immediately pain reduction. You also cut the healing time down by about 50%. We're now going to talk restorative. There are a number of procedures you can do a restorative in the mouth with the Oralase that works extremely well. One of them is small lesions on children and sometimes small lesions in older adults as well. In this case, we want to treat two sites. We want to treat the apex of the tooth. We also want to treat the CEJ or the lesion itself, depending if it's an open lesion or not. We're using bioinhibition because we want pain control at the apex. Depending on how much I want, I'll do either 8 or 16 joules at the apex. You will actually see two diagrams in your handout. One is the permanent teeth, showing you where you apply it. The second one is primary teeth, again showing you where to apply it. Remembering the roots in primary teeth are a lot shorter than on permanent teeth, so you want to make sure you're shining at the apex. The next restorative procedure I want to cover is reduction of post-op pain. Quite often we do fillings, the patient's frozen, and they're not sure where they're biting when we finish the procedure. We adjust the occlusion, and sometimes it's off. The patient comes back with post-op pain. The first thing I do is I check the occlusion, both centric and lateral. Then I apply the laser 8 joules for inhibition at the apex of the tooth and also at the CEJ. And this just makes the healing happen a lot faster and keeps our patients happy because often we've caused the problem by having the bite high. Quite often, if we have to cement a crown on, we have to freeze it, especially if it's a mandibular block for the lower molars. It's often very hard to get the occlusion adjusted properly because the patient does no feeling. So in those cases, I often can use the Oralase for analgesia and not have to freeze that patient. So the first thing I do is I apply 8 joules for inhibition at the apex of the tooth on each of the roots if necessary. I remove my temporary crown, and with some gel, I apply 4 joules to the buccal surface, 4 joules to the occlusal surface, 4 joules to the lingual. So even though I've used the dose that you would think for biostimulation, 4 plus 4 plus 4 equals 12, so that's inhibition. Then I go ahead and cement my crown, and 95% of the cases, I never have to freeze that patient. Whenever I'm applying the Oralase to the tooth itself, I use a desensitizing gel as well. It just conducts the light better into the tooth. I have found one of the ones I use commonly is Gluma G5. There's a number of other similar products out there, but you want something applied to the surface of the tooth when you're applying the laser into the tooth. Okay, we've talked on how we can eliminate the need for needles in a number of dental procedures. There's lots of times we still need to use needles. The laser can be very effective when we've used the needles for two procedures. One is making the anesthesia uptake faster, also getting rid of it faster. So if we want to have a faster uptake once we've done the injection, all we'd do is we'd hold it to the site where we've done the injection, 4 joules for stimulation, which increases circulation, which is going to get it into the site of the anesthetic faster. Second of all, if we want to get rid of it faster, we've got patients that say, I've got to get to a meeting. Am I going to be frozen for my meeting? In that case, we want to apply it 2 places. Again, stimulation. First, submandibular lymph nodes. Second of all, again, we apply it to the site where we've done the injection. If it's an infiltration, we apply it to the site where we have the infiltration. If it's a block, we want to apply it to the site where we place the block. One of the problems we run into a lot in our dental practice is patients who are gaggers, have nausea, and decide they want to throw up in the middle of our impressions. So laser can be a fantastic tool in reducing this. So where we want to go is somewhere called P6, which is 1 finger width above the second crease in the wrist. And what we're trying to do in this case is inhibit the acupuncture system. So you always want to be using 8 joules to inhibit it. And since gagging occurs on both sides of the mouth, we apply it bilaterally on both wrists. We're now going to cover endodontic procedures. We're going to cover 2 different procedures. We're going to cover root canals. We're going to cover pulpotomies. Root canals, there's several things we're going to cover with it. First of all, if I've done a complete root canal, at the end of the procedure, I apply 8 joules to the apex of the tooth. That reduces the post-op pain, also reduces the chance of any edema and post-op swelling. And I look at my x-ray to see where the apex of the tooth to make sure I'm shining it over the apex of the tooth. If it's a case where I've opened into it and there's a lot of bleeding, I sometimes put medication in the tooth. I apply it at the end, apex at the end of that, Also, if there's a lot of bleeding, I apply it directly into the tooth itself because the laser light will penetrate down the canals and reduce some of the irritation within that canal. The next thing we're going to cover is pulpotomies. Usually it's done in primary teeth. After I've uncovered the stumps of the pulp and cauterized the pulp, before any medications are placed inside the tooth, I take the laser, shine it as close as I can to those pulp stumps, and use 4 joules for stimulation, because what we want to do is we want a secondary dentin formed, and it also helps reducing the inflammation that's inside the tooth in this case. Next we're going to cover is dentin hypersensitivity. This is something we see an awful lot of. So the treatment mechanism that we're going to be using is always, again, we want to control pain, so we're doing 8 joules. First we apply to the apex of the tooth. So if it's an example, if it's on the buccal surface of the tooth, we're only applying it to the buccal roots. Then we take the gel, desensitizing gel like we talked about before. It's applied to the CEJ of the tooth, and we're applying 8 joules again. Now, you always apply to the apex first, because remember we talked before in the analgesia section, the laser is affecting the C fibers as well as releasing endorphins. So if we went right to the CEJ at the beginning, often it'd just be too sensitive when you apply the gel to the CEJ. So you always go to the apex first before you go to the CEJ. The next thing people often ask me is how long will it last? The biggest consideration in this is what caused it. In many cases, the cause of the dentin hypersensitivity is bruxism, which has caused the recession or clenching of the teeth. So often these patients, if I have a night guard associated with it, that helps keep the effects a lot longer. Many cases of it, I treat them once and never treat them again. Other times they've got habits that they keep up with, and I need to do it once a year, once every 2 years. Next we're going to cover is dental implants. So when the patient comes in and has an implant, there's 2 things that we're concerned with. One is we want the patients not to have pain after the procedure. Second of all, we want better healing of the implant. At the time the implant is placed, the most important thing for that patient is not to have post-op pain and swelling. So at that point we use 8 joules. We apply the laser directly into the implant site before the implant is placed. If I'm not sure at all of the quality of the bone, I bring the patient back twice a week for 2 weeks. I apply 4 joules for stimulation on both the buccal surface and the lingual surface halfway down the implant to get better quality bone formed. When we're talking orthodontics, there's 2 separate things we're going to talk about. One is pain control. The second thing is more rapid movement of the tooth. So when the patient first comes in, whether we're doing initial banding or doing separators, we apply the laser interproximally. We're using 8 joules to inhibit the pain they're getting from that banding or from the separator. When removing the teeth, we want to have the teeth move faster. So we are applying 4 joules at the center of rotation of the tooth, so the tooth will move faster. Another procedure we're going to discuss now is nerve regeneration. Patients may have had orthognathic surgery. It might be after the site of an injection where the nerve's been damaged. It might have doing surgery on the teeth itself, like a wisdom tooth. The nerve's been damaged, the patient complains, their jaws are numb. The laser can actually help regenerate that nerve. The procedure I'm going to tell you follows general surgical principles. Where you want to apply the laser is at the site of the injury and following all along to the path of the nerve. So we are always trying to use stimulation because we're trying to get the nerve to heal. So for an example, if it was a wisdom tooth or orthognathic surgery, I would apply it to the area where the surgery was done, much where you put a mandibular block. Now in this case, at the site of the injury, I've got to go quite a ways into the tissue. So actually I'd apply 8 joules in that area because I'm probably only getting 4 joules to the surgical site. So I would go there, then following the path of the nerve, the next place I would apply it would be the mental foramen. Then I would follow along the apex of the tooth because the nerve is now outside the bone. The apex of the 4, apex of the 3, apex of the 2, and apex of the 1. So I follow all along the path of the nerve. Each application is 4 joules. When I'm doing the nerve regeneration, I treat the patient 3 times a week for 3 weeks. Then I stop and do nothing. Because as I've treated them, the body started healing. So I wait those 3 weeks, let the body heal. I bring them back at the end of the 3 weeks and reevaluate. At that point, there's one of three things will happen. One is the nerve's totally healed, in which case I do no treatment. Second thing is it's better, but still not perfect, in which case I may repeat the treatment cycle, or there's no change at all, in which case that means I'm not going to regenerate the nerve and I stop. If you run into more difficult situations, one of the things in the guide is my email address. I basically, on a routine basis, help people with different situations. So feel free to contact me and we'll run through and make sure you're giving the patients the best treatment. After a long dental appointment, our patients often complain, such as root canals, long crown and bridge, long scaling appointments. They keep their jaw open. They say, the root canal didn't hurt. I got pain in my jaw and stiffness afterwards. If that's the case, the best thing to do for those patients is right at the end of the procedure, treat the muscle trismus. So it's a preventative procedure. What I like to do is use the home unit. It works the best. I apply it to two different areas. The muscle trismus is often occurring in the masseter muscle. I'm also trying to cover the joint and the lateral pterygoid. So the first point I apply it so just along the zygomatic arch where I'm covering the TMJ and covering the top half of the masseter muscle. I'm applying it for 8 joules, which with the home unit takes 3 minutes. I then move it down and cover the bottom half of the masseter muscle. So just to show you, I would take the unit, I would press start, and now you can see the red is visible red, the other is infrared. So we're applying it directly against the skin, and you'll notice also I've got the saran wrap covering it. This is so I don't have to do any wipe down or anything after I'm done. I just take the saran wrap off and it remains sterile. In case you don't have a home unit, you can accomplish the same procedure using the Oralase. In this case, I set it to 8 joules. I start off in the same area, and instead of holding it in one place, I move it. So I start over the TMJ, move it across the zygomatic arch, back and forth, and then up and down along the masseter muscle. I'll repeat this 5 or 6 times so I get the coverage of the whole muscle area. The next procedure we're going to talk about is sinusitis. The laser is very effective in draining the sinuses, helping with sinus pain, and very effective as well in the case of patients that get sinus problems with allergies. So the first place I apply the laser is the submandibular lymph nodes. Again, because it's the lymph nodes, I always want stimulation. So 4 joules, the submandibular lymph nodes. That's the first application. The next area I want to treat is the maxillary sinus. So for this, I like to use the home unit. I apply 8 joules per centimeter squared, apply it directly on top of the maxillary sinus. That's going to take me 3 minutes on that side. I'm then going to go to the other side, apply another 8 joules. Again, that's going to take me another 3 minutes. The next place I like to apply it is to the frontal and ethmoid sinuses. So in this case, the glasses are going to be in the way, so we remove the glasses, and we put a wet gauze over the patient's eyes. I then take the Oralase and I apply 8 joules over top of the frontal sinus, then over top of the ethmoid sinus on both sides. The first hygiene procedure we're going to discuss is dentin hypersensitivity. Hygienists run into this very frequently. The treatment mechanism that we're going to be using is always, again, we want to control pain, so we're doing 8 joules. First, we apply to the apex of the tooth. So if it's an example, if it's on the buccal surface of the tooth, we're only applying it to the buccal roots. Then we take the gel, desensitizing gel like we talked about before. It's applied to the CEJ of the tooth, and we're applying 8 joules again. Now, you always apply to the apex first, because remember we talked before in the analgesia section, the laser is affecting the C fibers as well as releasing endorphins. So if we went right to the CEJ at the beginning, often it'd just be too sensitive when you apply the gel to the CEJ. So you always go to the apex first before you go to the CEJ. The next thing people often ask me is how long will it last? The biggest consideration in this is what caused it. In many cases, the cause of the dentin hypersensitivity is bruxism, which has caused the recession or clenching of the teeth. So often these patients, if I have a night guard associated with it, that helps keep the effects a lot longer. Many cases of it, I treat them once and never treat them again. Other times, they've got habits that they keep up with, and I need to do it Once a year, once every 2 years. Okay, another procedure we want to discuss is bleeding after scaling. Quite often when you do a deep scaling, there's a lot of bleeding associated with it. This is an ideal situation for photobiomodulation. This is an acute reaction, and lasers work best when you've got acute pain. So the treatment modality for you to use is take it and set it at 2 joules, apply it all the way around the mouth, overlapping like the enclosed diagram, and you cover the whole mouth, and you'll get much better healing after your scaling procedures. Okay, another procedure hygienists often run into is the patients are very sensitive. So one of the things you can do with the laser is use it for dental analgesia. In most cases, you don't need the dentist to come in and have to freeze the teeth. So you apply 8 joules at the apex, and then you apply 8 joules at the CEJ, as you can see in the slides that we've attached. If it's all the teeth, it's going to do the whole mouth or the appropriate teeth. If you should have a patient that comes into your chair with a periodontal abscess, the laser light will not kill the bacteria, so the only thing you're going to be working on is the immune system. So in that case, we're going to be treating the submandibular lymph nodes. For the lymph nodes, it's always stimulation, so 4 joules to the submandibular lymph nodes, then carry on with your periodontal treatment. One of the things probably you're very interested in, if I buy this equipment, is a return on my investment. And when I talk of return on investments, I think there's 2 things that we could be talking about. There's direct return on investment, in other words, direct reimbursement for specific codes, and many codes in Canada, as well as many in the US, are covered directly. Then there's also indirect reimbursement. Indirect reimbursement is that if you do something that doesn't cause pain, the patient is in your chair. Those patients will have to come back to your chair. They're in your chair, taking up your chair time, and you're treating them for free. So if you can not have them in their chair that time, you can use that time more productively for doing other procedures. One of the things that's really important with it is that you're using less prescriptions. Patients don't want to be taking drugs. And this is especially true in these times where there's so much concern over opioid prescriptions. Just imagine if you don't have to write the patient's prescriptions after the surgery, how much they're going to appreciate that, and they're going to tell their friends about it. It is a truly big practice builder.